Our fourth speaker will be Dr. Pyoeng Gyun Choe from Seoul National University Hospital. He will talk about clinical experience with COVID-19 patients. Dr. Choe, please.
Who introduced me. I'm Dr. Pyoeng Gyun Choe. I'm ID physician of Seoul National University Hospital, which is the government-designated treatment center for severe COVID-19 patients. We have some experience for treating severe patients, and I want to share our experience with you. On February 24th, Chinese Center for Disease Control published their surveillance data as of February 11th. According to this report, among 44,672 laboratory confirmed COVID-19 patients, 81% were classified as mild, which included non-pneumonia and mild pneumonia. This means that over 81% patients, we can treat them as based on outpatient setting. 90% were classified as severe, which was characterized by dyspnea, respiratory frequency over than 13 per minute, blood oxygen saturation below 93%, and or lung infiltrate over more than 15% within 20 to 48 hours. Of these severe patients, 5% of the patients were progressed to critical cases that exhibited respiratory failure, septic shock, or multi-organ failure. The overall case fatality rate was 2.3%. Mortality rate increased with age, so for patients over the age of 18, the mortality rate was 40.8%. Mortality occurred only in patients classified as critical, with a mortality rate of this group is 50%. On February 2019, a detailed clinical characteristics of 1,099 patients was released to New England Journal of Medicine. What's interesting about this data is that 35.8% of the patients who were classified as non-severe on admission point also received oxygen therapy during their hospitalization, and 2.8% of the patients were admitted to intensive care unit. From the very early data from Wuhan, the median time for onset of symptom to first hospital admission was 7 days. To shortness of breath was 8 days. To ARDS was 9 days, and to mechanical ventilation was 10.5 days. Recently, more detailed data about the clinical course in severe patients were published. Median time from illness onset to dyspnea was similar between survivor and non-survivor group with 7 days. And the median duration of dyspnea of 13 days for survivor groups. Sepsis developed at the median of 9 days after illness onset among all patients, followed by ARDS, acute cardiac injury, and acute kidney injury, and secondary infection and death. In Korea, the first COVID-19 case was a traveler from Wuhan, China in January 19th. Before February 20th, a huge outbreak occurred among a religious group, Shincheonji, in Daegu. Korean government has maintained a strong quarantine system, and before that, during the strong quarantine system, the spread of COVID-19 was limited, and patients can be detected in the very early course of disease by the quarantine system. Recently, the clinical characteristics of the earliest 28 COVID-19 cases were published in Korean Medical Journal Science. And the most common symptom at the time of admission for isolation were cough, about 13%, and diarrhea was present as 3 patients among the initial symptoms. Of the 28 patients, 2 patients were asymptomatic when they were confirmed as COVID-19. The clinical picture of COVID-19 during the predominant phase was insidious and wild. Fever was absent in 75% of the patients at the time of admission. Throat symptoms such as pain, discomfort, and glove sensation and cough were ranked as relatively common, but only 1/3 had these symptoms. As the prominent symptoms were mild and did not begin abruptly, most of the patients were not able to tell exactly when they had become ill. And because of this benign nature of the predominant symptom, they did not realize that they had been infected with SARS-CoV-2 and went out to carry on usual activities while spreading the virus inadvertently. I think this is the key clinical characteristic of this highly transferable of this COVID-19, and so universal social distancing is the essential to prevent widespread of this virus. The most common finding of CT scan were bilateral ground-glass opacity in the periphery of the lungs. Although they had radiological pneumonia, they did not feel unwell and were able to carry on their daily activities as usual. It means they got some walking pneumonia. But the titer of SARS-CoV shedding from the upper respiratory tract was very high from the prodromal phase of the illness until day 5 of illness. In some patients, dense nodular regions were found. 70 patients developed fever and became afebrile during the hospitalization, and the median day of defeverance was 9 days after symptom onset. The median day of isolation was 18 days after symptom onset. While neutropenia or neutropenia were not common, regardless of clinical severity, lymphopenia were more common in severe cases than mild cases during the clinical course. High level of C-reactive protein in the blood were more frequently observed in severe cases as the clinical course became worse during the 5 to 7 day period after symptom onset. The most important treatment for COVID-19 patients, especially for severe patients, is the best supportive care. It includes antibiotics, hydration, oxygen therapy, mechanical ventilator support when indicated. ECMO can be life-saving in patients with severe form of ARDS patient. However, to maintain proper ECMO program in hospital, it needs some intensive resource utilization, substantial staff training, and multidisciplinary team. As you know, no antiviral drugs have been proven to be effective with randomized control trial now. Let me introduce one severe COVID-19 case treated in our hospital. This patient was an 81-year-old male and visited the emergency room of local hospital on February 15th for chest discomfort that began 2 weeks before. CT scan were performed and bilateral ground glass opacity were observed on both lung fields, so the ER staff suspected COVID-19 and performed PCR test. And he was confirmed with SARS-CoV-2 infection in real-time RT-PCR assay and admitted to our biocontaminant unit on February 16th. The initial CT scan taken on 12 days of illness showed bilateral ground glass opacities. This graph plots the change in body temperature and oxygen saturation for 2 weeks from February 16th to February 2019th. The blue line is body temperature and the red line is oxygen saturation. I'm sorry that the letter of this graph is too small. By February 24th, the patient continued to have a fever, and the lung infiltrate gradually increased in his chest radiography, but the oxygen demand remained similar. But at February 5th, the patient abruptly deteriorated and became in need of intubation and mechanical ventilation, and then ARDS progressed rapidly. So we applied ECMO treatment 2 days later. And this chest radiography showed taken after we applied the ECMO. This graph represents the next 2 weeks of clinical course. Fortunately, ECMO was successfully weaned after 2 weeks of the therapy. And during the ECMO treatment, acute kidney injury occurred and continuous renal replacement therapy was performed for 5 days. The viral RNA was detected until the 37 days of the illness. And the patient is still being treated in the intensive care unit now and is trying to mechanical ventilator weaning. Our experience shows that severe COVID patients have the following characteristics. There is some mismatch between the severity of the chest radiography and the clinical symptoms. Even when the chest radiography showed extensive infiltration in lungs, but patients often do not complain of shortness of breath. And the patient condition may remain relatively stable for a while, but may deteriorate rapidly. And we feel that the treatment response to best supportive cares seems to be better than that of the burst COVID patient when we experienced. Thank you for listening.